takes you higher. I will forever be intertwined with you. Where the sun never goes down and time has slowed down. Would it be too crazy if we decided to stay forever? Decided to stay forever, forever.
You gotta put your past behind you. Look, kid, bad things happen, and you can't do anything about it, right?
Right.
Wrong! When the world turns its back on you, you turn your back on the world.
Well, that's not what I was told.
Then maybe you need a new lesson. Repeat after me. Hakuna Matata.
What?
Hakuna Matata. It means no worries.
Repeat after me. Hakuna Matata.
Hakuna Matata. It means no worries.
La movilización social a partir del 18 de octubre nos trajo esperanza, temores, alegrías, incertidumbre, un torbellino de emociones. A esto se agregó la pandemia, lo que ha llevado a los chilenos a vivir tiempos difíciles y extraños. Nos hemos visto amenazados por el riesgo de contagio de COVID-19, restringidos por el confinamiento obligado y separados de nuestros cercanos. Algunos nos hemos enfermado, incluso gravemente, teniendo que acudir al hospital. También hemos perdido a seres queridos sin poder participar en los necesarios rituales de despedida a los que estábamos acostumbrados. En este Chile que compartimos, la pandemia ha dejado aún más en evidencia la profunda inequidad socioeconómica, el poco respeto por la diversidad entre nosotros, el maltrato hacia quienes son distintos y la indiferencia hacia sus necesidades. A algunos, la enfermedad, el confinamiento y el impacto económico los ha golpeado más que a otros, siendo los pobres, las personas con trabajos precarios, los profesionales de la salud de la primera línea, los niños, las mujeres, las personas mayores y los migrantes, quienes han enfrentado más dificultades en este periodo. A muchos, el día a día se nos ha hecho más difícil. Transportarnos, estudiar, trabajar, cuidar a los hijos, hacer deporte, recrearnos, compartir, salir de paseo. Si bien todo esto ha afectado nuestra salud mental, también esta crisis ha sido una oportunidad de aprender muchas cosas, a comunicarnos y querernos a la distancia, a mirar hacia adentro y descubrir cómo estamos, a cambiar nuestras prioridades y, sobre todo, a redescubrir la importancia de la solidaridad y la colaboración para salir adelante. Sabemos, a partir de los estudios que realizan los científicos de MIDAP, que todos estos aprendizajes protegen de la ansiedad y de la depresión. Al vincularnos con otros y al apoyarnos mutuamente, fortalecemos nuestro bienestar psicológico y protegemos nuestra salud mental. En estos aprendizajes han sido los sectores más pobres los que nos han enseñado sobre la importancia de apoyarnos mutuamente, de organizarnos junto a nuestros vecinos, de cuidar a los más necesitados, compartiendo en las ollas comunes, ayudando a las personas mayores y cuidando a los enfermos. Hemos visto taxistas voluntarios llevando pacientes y medicamentos y a los equipos de salud visitándonos en nuestras casas. Los trabajadores de la salud han sido un ejemplo en su entrega y compromiso. Y, quizás lo más importante, nos hemos ido reencontrando con la participación y la vida en comunidad. En esta primavera la participación nos invita a encontrarnos muy de a poco en las calles y en paz, conversando para refundar un país de esperanza, un país más equitativo, un sol primaveral que ilumine a un Chile generoso, altruista, inclusivo y solidario que garantice las necesidades básicas para todos sus habitantes y donde podamos confiar los unos en los otros. Encontrémonos en la participación por un Chile más justo y alegre para todas y todos.
Good morning, everyone. We are starting our third day of our Latin American summer school, and it's really nice to see you all this morning. And we will start our activities today with the lecture of my dear colleague, Juan Pablo Jimenez. Juan Pablo Jimenez is an associate researcher and director of MIDAP. He holds a Doctor of Medicine from the University of Ulm in Germany, and he's a full professor of psychiatry at the Department of Psychiatry and Mental Health at the Faculty of Medicine at the University of Chile. He's a psychiatrist and a psychoanalyst and has had a long career and made a significant contribution to the field in Chile and also internationally. And Juan Pablo Jimenez will talk about the heterogeneity of depression, from evidence-based medicine to the individual clinical case. Juan Pablo, it's great to have you here, and please, you can start your talk.
Good morning to all of you. I'm delighted to be able to share with you in this workshop a topic that I consider very important, namely the interface between research and clinical practice. I am sure that most of you are currently working with patients as well as being interested in research. The word of clinical practice and research has never gotten along very well. I will try to show you in this talk to the topic of heterogeneity of depression, how to use research findings in a particular clinical case. Well, I have no conflict of interest to declare. And these are the topics I will talk about today. First, I will tell you who we are at Meetup and what is our perspective of the study of depression. I will then go on to place face-to-face the heterogeneity of depression that we discover in research and the heterogeneity that we clinicians encounter in our daily practice. Later on, I will summarize the most important findings, what we have learned in these years of research at Meetup, namely the concept of complex pathology. In the second part of my presentation, I will talk about the different attitudes of scientists and professionals towards mental health and how the clinician practice guidelines have been received by mental health professionals. Finally, I will highlight the centrality of clinical judgment in the work with patients, and I will present a stepwise approach to the diagnosis of depression in a particular case, considering what we have learned from research. Well, in 1992, we brought together a small group of psychologists and psychiatrists interested in psychotherapy research and found the Chilean and Latin American chapter of the Society for Psychotherapy Research. This group worked actively during the 90s. At the end of the last century, we decided that it was necessary to train researchers in a university-based program. Thus, the doctoral program in psychotherapy was born as an inter-university and international program between the Catholic University and the University of Chile. The University of Heidelberg in Germany was our international partner. Most of the current Meetup researchers have graduated from this program. This group of researchers, led by Marianne Krause, applied and earned a millennium nucleus that after 3 years became in 2014 the current Millennium Institute for Research in Depression and Personality. Next. Well, in this context, these are the scientific objectives of Meetup. First, to generate scientific knowledge based on a multi-dimensional understanding of depression in interaction with personality. Second, to maximize the effectiveness of interventions through the identification of mechanisms of therapeutic change in primary, secondary, and tertiary prevention. These goals can only be achieved through the generation both of an advanced human capital and a relevant network of collaboration that ensures that dissemination of the insights achieved in the fields of healthcare, education, the working field, and the general public. Next. Our group currently includes more than 180 researchers of different hierarchical level coming from many Chilean universities. And in relation with our budget, that is the institute received from the Millennium Program, just over $2.5 million during the last 6 years. Well, next one. Our mission as a Millennium Institute is primarily scientific. What have we done in this time? Basically, we have built a map of depression in its interaction with personality in our country, identifying the main variables and factors that can explain its high epidemiological prevalence. Our idea is that by identifying these factors, we can develop and propose interventions and public policies that diminish the individual and social impact of depression. And why depression? It's the next slide. The reality is that, and you know that already, is that in Chile we have about 20% more prevalence of depression than the world average. That is the fact. And in addition, we think that it's not possible to study depression separated from the rest of the personality function of individual, because personality is a predisposing or vulnerability factor for development of depression, influence the way depression manifests itself clinically, and determine the process of psychological change and the efficacy of treatment. So this is the model that guided our work. It's a multidimensional perspective where each dimension has an impact on the other. For the time being, the model leads us to discover correlation and association between dimensions and requires studies that simultaneously consider different dimensions. We are participating in longitudinal studies that will provide us with more information on causality. I can't be more specific right now in this issue. Well, that is our perspective. We embrace an explanatory and integrative pluralism. This schema tries to convey the complexity of the study of the depression, that try to study simultaneously 1, 2, or 3, or even more levels or perspective. That's the reason why we are trying to go from an interdisciplinary to a trans-interdisciplinary perspective. Well, it's said, about our scientific output. It's said that in science, if you don't publish, you just don't exist. For this reason, we have put special effort in scientific publications. Of the near 300 papers published so far, more than 250 papers have been published in journals indexed in WOS or Scopus. In short, what have we learned about depression in this 7 years of meaningful learning? What have we learned? Well, first, that depression is a polysemantic concept, an heterogeneous psychopathological construct that is embedded in and depends on several psychological functions that we group under the concept of personality. This conception connects us with the current conception of paradox, the conception of research domain criteria. We also have learned that depression is a complex phenomena that is a combination of clinical, that is diagnostic, biological, socioeconomic, cultural, environmental, and behavioral factors that are statistically associated with clinical prognosis. The etiological importance of social determinants as another finding, including early life adversity, is very relevant in our findings. And that different, and we have also learned that different depressive profiles related to self-critical or dependent personality style with phenotypic, physiological, and neurophysiological specificity require differentiated psychotherapeutic strategy. So depression is not an homogeneous disease, and its treatment should be adjusted to the type of depressive profile exhibited by the patient. So there are two central concepts that stand out, and that is first the concept of complex pathology and the etiological importance of early life adversity as part of the psychosocial determinant. I will emphasize more about what we understand as complex pathology. As I said, it's a combination of clinical, biological, socioeconomical, environmental, cultural, behavioral factors that are statistically associated with clinical prognosis. That is, it goes far beyond the clinical diagnosis. That is important to keep in mind. And complex pathology includes that implies that individual patients may have protective or risk factors in any of these domains, and their total complexity level results from the sum of the risk of all the risk. That is the concept of cumulative complexity. Well, we prefer the concept of complexity over that of severity, which is the last one. Severity is currently used by DSM and ICD, because complexity is a better concept for indication and scaling of treatment, and complexity includes syndromatic information, biological information, and socio-economic variables. Each is a larger complex. Well, the idea is the next one. The idea, we are the peak factor. The idea of complexity is associated with a concept coined a few years ago by Caspi and colleagues in 2014. This author examined the structure of psychopathology, considering the dimensionality, persistence, coexistence, and sequential comorbidity of mental disorders in a cohort over 20 years. Factor P, a common structuring factor in different psychiatric diagnoses, is found to be related to higher levels of life impairment, greater family history of mental disorders, higher rates of negative histories during the life development, and more compromised early brain function. It is therefore a common element in the origin, development, and absence of disorders, which leads the author to advocate a transdiagnostic approach in psychiatry. And this is the scheme that they present. The higher complexity, the higher P factor is the higher complexity. That means that a particular patient with a high P factor, more contextual etiopatogenic factors. But the next one, but we have in the study of depression and in psychiatry and mental health in general, we face a difficult problem that during the 20th century was described by Kenneth Kendall as the battle of paradigms. There continue to be many scientific nowadays in psychiatry and in the clinical practice, there continue to be many scientific perspective and clinical and diagnostic orientation, but very little conversation among them. Do you all know this myth of this tale about the elephant and the wise blind man in India? No, everyone discover a different part of the phenomenon and think this is the whole phenomenon. When you are embracing a pluralistic perspective, you have to take all this perspective together in a way that you can understand complexity, and this is the only way to deal with a particular patient. So it must say that if we want to investigate the field of depression, we must face of the problem of phenotypic pleomorphism. I don't delve on this problem because Alex then touches on its extensively and brilliant in talk 2 days ago. Well, the problem is, the criteria DSM-5 to diagnose major depressive disorders. Alex talk about theoretical heterogeneity, talk about heterogeneity due to instrumentation, to the empirical heterogeneity, and about the centrality of different symptoms. All this leads to the idea that major depression is not a valid construct. I am fully aware about the importance of this statement. As early as 2010, Mario Mach, a very important figure in the world psychiatry, reviewed the MDD construct and conclude that it does not meet any of the current methodological criteria to be considered a valid construct. If this is so, research in diagnosis and treatment on depression is based on a construct of dubious validity. Then the entire edifice of findings, of research findings, has feet of clay. That is a very important problem we have. So that is what Thomas Insel, the statement from Thomas Insel, the former director of NIMH, who introduced the concept of research domain criteria. He said the weakness of DSM is its lack of validity. Unlike our definition of ischemic heart disease, lymphoma, of AIDS, the DSM diagnoses are based on a consensus about clusters of clinical symptoms, not any objective laboratory measure. In the rest of medicine, this could be equivalent to creating diagnosis system based on the nature of chest pain or the quality of fever. Indeed, symptom-based diagnosis, one common in other areas of medicine, has been largely replaced in the past half-century as we have understood the symptoms alone rarely indicate the best choice of treatment. Well, so this is the task then of 21st century psychiatry, to move from the battle of paradigm to integrative pluralism, to go beyond biology, psychology, and sociocultural, and to integrate ethiopathological levels, and considering a bi-directional causality, bottom-up and top-down, and to find a middle ground that is a kind of functional dimension for psychiatry and mental health explanation that can be built on the ability to move up to other areas of psychological and environmental process, and to move down to molecular aspect of neuroscience. So we have different etiological explanations in depression, different theories or models, different disciplines. This is one of this, here we have 7 levels of explanation. But what do we know about the interaction of these different levels of explanation? Very little. And we know that there exists a top-down and a bottom-up causality with multiple inter-level loops. So the most appropriate design models to face this problem is the multi-level research design. Well, in what will follow, I will present the ideas contained in chapter 16 of this book on theories and ethiopathogenic models in depression, to be published by Springer in December of this year, which has precisely the title of Model in Depression and Clinical Judgment, or how to use different ethiopathogenic models with a particular patients. This book reviews the different theories and models that seeks to explain the causes of depression from different perspectives, from the molecular to the to the socio-cultural level. The aim of this book is to provide professionals such as clinical psychologists and psychiatrists with a better understanding of the interaction of the different etiopathogenic levels in order to help them make better therapeutic decisions in the treatment of patients with depression. And we are now facing the problem of clinical pleomorphism. Because we know, clinicians know, that that depression is an extremely heterogeneous condition. Depression can be, we know, a psychiatric diagnosis like MDD, bipolar disorders, dysthymia, cyclothymia, etc. Can be the response to a tragedy such as the death of a family member, can be an expression of a pessimistic way of seeing life in the case of depressive personality, can be a transitory emotional state, a state underlying complaints such as fatigue, weakness, lack of energy, insomnia, back pain, headache, or the response to or expression of an underlying medical condition of its treatment. And to make the problem even more complicated, in recent decades, sociologists and mental health researchers have further expanded the polysemantic character of depression, and now depression is also an idiomatic expression for subjective distress, individual and collective. At this point, I must make a watershed statement, which is the different perspective and attitude in which a scientist and a professional face the issue of mental health. And to clarify the point, I will read a quote from Kenneth Kendler, a geneticist, psychiatrist, and epidemiologist, as well as an epistemologist of psychiatry. He says, "Our central goal as a medical discipline is the alleviation of the human suffering that results from dysfunctional alteration in certain domains of first-person subjective experience, such as mood, perception, and cognition. Our nosological constructs are largely composed of descriptions of first-person experiences, like sad mood, hallucinations, or irrational fears. The clinical work of psychiatry or clinical psychology constantly requires us to assess and interpret the first-person report of our patients. Many of the target symptoms that we treat can only be evaluated by asking our patient about the subjective experience. While we want to take advantage of the many advances in the neuroscience and molecular biology, this cannot be done at the expense of abandoning our grounding in the world of human mental suffering." I think from this quotation, I think it's clear that clinical work are different than scientific work. Because we start from the assumption that the work of the clinician differs from the work of a scientist, in that the clinician is faced with the ethical task of understanding and helping a patient who seeks to alleviate his or her suffering. Ideally, the clinician working with patients should be able to use all the knowledge accumulated by the natural science, since he or she has an ethical mission to fulfill, not as a scientist, but as a healthcare professional. Now, you can find the difference between the scientist who works with data about people and the professional who works with people, directly with people, with other kind of data ideographic data, not nomothetic of general data about people. Evidence-based medicine is a movement of scientific renewal that seeks to make scientific findings available for diagnosis and treatment of patients. This is a way science tried to impact clinical work. And the most typical instrument of evidence-based medicines is the clinical practice guidelines. That are suggestions or recommendations for specific professional behavior, efforts of conduct for psychiatrists, psychologists, and other mental health professionals. Clinical guidelines differ from algorithm in that these are mandatory and are usually accompanied by an implementation protocol. And the objective of the clinical guideline is to facilitate the ongoing systematic development of the profession and to help ensure a high standard of professional practice. But they are not intended to be mandatory or exhaustive and may not be applicable to all professional and clinical situations. They are not definitive and do not override the judgment of clinician, the so-called clinical judgment. And clinical practice guidelines are imperfect instruments that are constantly being improved. Recently, the American, in 2 years ago, the Clinical Psychological Society published clinical practice guidelines for the treatment of depressive disorders. But the novelty of this recent guideline is that the expert panel that developed the guideline was composed of health professionals from the field of psychology, psychiatry, and primary care, as well as community members who reported having depression. They consulted the patient themselves. This is very important. And some years ago, you can see here what the 10 general recommendations that the American Psychiatric Association published for the diagnosis of depression. And this goes far beyond the psychopathological aspect, including contextual dimension of the act of diagnosis itself, like the recommendation of establishing and maintaining the therapeutic alliance, assessing the patient safety, establishing an appropriate indication and set of treatment, assessing functional impairment and quality of life, connecting the patient with an interdisciplinary team, monitoring the patient response to the indication and treatment, etc., etc., educating the patients and the family, etc. No? But problems persist because clinical practice guidelines cannot escape the limitation of the diagnosis system on which they are based, DSM and ICD. In an attempt to improve coverage of clinical heterogeneity, we have seen an increasing inflation of diagnosis over the years, from DSM-2 or DSM-3 to DSM-5. More and more categories and syndromes are included in the classification. The World Health Organization Department of Mental Health Substance Abuse conducted a worldwide survey of near 5,000 psychiatrists from 44 countries on the use of diagnostic classification systems in clinical practice and the desirable features of a classification of mental disorder. On what have they found? They found that the study on acceptability and usefulness of diagnostic system show that participants overwhelmingly prefer a simpler diagnosis system with 100 or fewer categories. Most of the respondents of this survey were receptive to a system that incorporates a dimensional component. Significant minority of psychiatrists from Latin America and Asia reported problems with the cross-cultural applicability of existing classification. Overall, rating of the ease of use and goodness of fit of specific ICD-10 categories were quite high, but several categories were described as having little utility in clinical practice. However, the diagnostic task is even more problematic, as ethnographic studies have shown that culture not only shapes depressive experience, because cultural and administrative settings inform expert practice and the conception associated with the psychiatrist's concept of depression itself. We have problems that persist. We know that psychiatrist adherence to clinical practice guidelines is low. Among general practitioners at the primary care level, the situation is even more worse and dramatic. Quantitative and qualitative studies show that general practitioners use diagnosis strategies that differ markedly from the evidence-based diagnostic criteria for depressive disorders using psychiatry-oriented classification systems. And the results of this research illuminate the complex dilemma faced by general practitioners in the treatment of depression, which seems to be characterized by a sense of dissonance between the medicalization of depression and a sense of its social determinant. The author of two systematic reviews of qualitative studies conclude that clinical guidelines are not appropriate for the primary care setting, and that primary care physicians use their intuition and relational skills more than clinical guidelines to screen for depression. Thus, a discrepancy appears between the psychosocial causality model of depression and the pharmacological model of its treatment. Next one. The diagnosis system in use attempt to be atheoretical with respect to etiopathogenesis. However, there is a theory implicit in them, namely the biomedical conception of depression, because almost all guidelines in use emphasize medical treatment, antidepressants, based on the causal theories of intersynaptic neurotransmission, ignoring the fact that depression is a complex condition where the etiopathogenesis may be associated with both bottom-up and top-down biopsychosocial mechanism. The next one. One case in which nosology cannot dispense with the theology is in the matter of when and how a depression can and should be distinguished from a grieving process. And in these cases, it is inevitable to resort to clinical judgment. And we are coming to the core of my presentation, the concept of clinical judgment. This is an old question and concern in the philosophy of medicine, because the clinician needs to predict how the patient will react to such a diagnosis or indication, treatment indication. And this prediction is a matter of practical wisdom, not theoretical reasoning. Practical reasoning seeks to answer from a series of alternatives, none of which has yet been realized, which is the best in terms of what to do. Therefore, it is not a question of facts and their explanation, but of values. What is preferable to do? In this way, science gives way to ethics. The pioneers, next one, the pioneer of the evidence-based medicine movement placed great importance of professional expertise in the clinical decision-making process. and I quote, external clinical evidence can inform but never substitute for individual clinical expertise. And it is this expertise does decide, that is clinical judgment, whether the external evidence applies to the individual patient at all, and if so, how it should be integrated into a clinical decision. It is clear that is something that the pioneers, the founder of the evidence-based movement, have very clear in mind. But what is clinical judgment? Clinical judgment refers to the cognitive and affective process that allows health professionals to reach a conclusion based on objective and subjective information about the patient. Clinical judgment is developed through practice, experience, knowledge, and continuous critical analysis. It extends to all clinical areas: diagnosis, treatment or therapy, communication, and decision-making. Clinical judgment can involve both automatic, intuitive reasoning and analytical reflective reasonings. These types of reasoning are not mutually exclusive. Healthcare professionals may change their judgment strategies depending on the circumstances they encounter. Moreover, because the cognitive processes involved in clinical judgment are complex, they are prone to various cognitive errors, such as faulty heuristic, cognitive biases, and affective influence. That is what we psychoanalysts call the countertransferential problems. Clinical reasoning and clinical judgment are goal-oriented, directed towards clinical action. Such judgments are often made with clinicians working with imperfect information and uncertainty about prognosis and therapeutic efficacy. Uncertainty arises from a lack of evidence, conflicting interpretation of evidence, inability to access evidence in a timely manner, concerns about the application of aggregate statistical data to individual cases, and lack of clarity regarding patient preference and values. In this sense, clinical judgment has a strong ethical component and is based more on practical wisdom than on abstract knowledge. And clinicians cannot dispense with etiological theories when diagnosing and indicating treatment. A merely descriptive symptomatic diagnosis, like DSM or ICD, that is, one does disregard the causal context and consideration of the patient's psychosocial circumstance, is a soulless diagnosis, which is likely to prevent activating the patient engagement and collaboration. Critical self-reflection, that's the next slides, enables mental health professionals to listen carefully to patient distress, recognize their own mistakes, improve the technical skills, make evidence-based decisions, and clarify their values so that they can act with compassion, technical competence, presence, and insight. Explicit clinical knowledge is easily taught, accessible to awareness, quantifiable, and easily translated to evidence-based guideline. But tacit knowledge, however, is usually learned through observation and practice, includes previous experience, theories in action, and deeply held values, and is often applied more inductively. Mindful professionals use various means to enhance their capacity for self-control and at every moment to bring out that tacit personal knowledge and deep values, to use peripheral vision and subsidiary awareness to become aware of new information and perspective, and to adopt curiosity in both ordinary and novel situations. Okay. In our teaching, we regularly recommend our initial interviews with a consultant and with a case formulation, because case formulation is a framework or picture that informs the choice of psychopharmacological and or psychological treatment, thus providing a bridge between diagnostic assessment and treatment phase to guide treatment options. Conversely, using purely psychiatric diagnosis to guide treatments limits individualized care. Using a care formulation approach, regardless of diagnostic classification, provides flexibility in linking assessment and intervention. And case formulation is a clinical method that integrates multiple judgments about etiology, patient reasons for consulting an expert, and symptomatology. Well, in our Springer book, we propose a stepwise, and I am ending my talk, a stepwise process of diagnosis in depression that considers not only the psychopathological aspect that comprise the diagnosis system, but also the contextual factor that research has shown to be important in etiology and treatment prognosis. I cannot go into the scientific studies on which these recommendations are based. Jaime Delgadillo's talk yesterday made a brilliant contribution in this sense. Our proposal is highly complementary to his. On the first, we are proposing a 5-step depression diagnosis that considers complexity and integrates the concept. The first recommendation, we have recommendation, and the main question we have to answer in each step. The first question, of course, is the following. Does the patient have depression? Is his depression of organic or psychiatric origin? Is the patient depression of bipolar type? What subtype of depression is it? Well, that is the psychopathological step, the first steps. The second steps. The question are, does the patient have an affective temperament, that is depressive personality? What type of personality style predominate in the patient, analytic or introjective? In what way has the personality determined, conditioned, or perpetuated the symptomatology? Does the patient have a history of childhood trauma? How does the trauma influence the patient's symptoms, treatment, indication, and prognosis? This second step is the first level of contextual level, the context of personality and the biography, where the early trauma reveals its importance. The third step is more psychodynamic, I should say. The question is, what is the nature of the situation the patient is reacting to or defending against? What has been the cost of the problem to the patient? What might be consequences of a psychological or emotional change in the patient life? Here, in these steps, we try to explore the triggering situation and the relational context with another context, not personality or biography, but the interpersonal, relational context in which symptoms develop. For instance, the experience of loss, separation, failure, humiliation, along with their degree of reactivity. The fourth steps, recommendation, recommend to consider the patient's social and cultural environment and the relationship with the health system involved. The corresponding question is how the patient's environment, culture, social milieu, and health system influence symptoms, onset, persistence, and or response to intervention. These kind of questions are more and more important in Chile and in many Latin American countries because of the issue of migration, of course. We're facing now very different patients coming from other countries of our regions. The fifth steps, establish a diagnosis and differential indication for treatment that consists of a process of negotiation between the patient's own ethiopathogenic theories, his or her expectation for treatment, and the clinician's judgment about the nature of the problem. In this step, the clinician must consider a clinical informed treatment indication for both pharmacotherapy and psychotherapy. The question in this fifth step is, what will be the working hypothesis that will guide the decision-making process between patient and therapist? What treatment is most appropriate for this particular patient? What are the expected outcome of the treatment? And the last one, I put it a 5-step depression diagnosis, but it's a 6-step depression diagnosis process. The final recommendation is the question in this, the last step is, how did this particular patient become depressed? It's the last point of a case formulation. Why the patient depressed now and not 2 years ago, not 5 years ago? We have a synthetic statement at the end. The clinician must finally consider depression as a disorder that can be reached from several interrelated pathways: biology, personality, environment, etc. And that, depending on how this combination occurs, presents clinically through several subtypes whose differentiation has diagnostic, prognostic, and therapeutic implication. Okay, guys, thanks for your attention. That is what I wanted to convey this morning to you.
Thing that we all see, same old thing that keeps me keen, but I just wanna be alone with you. Just wanna be alone with you. Same old thing that keeps me around. If you wanna come around, baby, it's cool. And if you wanna fuck around, baby, I do. Just wanna be alone with you. With you. With you.